Participants. Alex argues for universal healthcare. Blair argues against or urges strong caution. Alex, let's start with facts we can measure. Countries that guarantee coverage for everyone generally spend less on administration and negotiate lower prices for the same services and drugs. That means more of each health dollar goes to clinical care rather than paperwork. When you add the evidence that expanding insurance reduces mortality among low-income adults and cuts deaths considered amenable to healthcare, the case for universal coverage is not abstract. It's about lives saved and waste avoided. Blair, lower administration and prices can be positives, but the system is more than a balance sheet. When you constrain budgets, you create queues unless you scale capacity and manage demand. Many universal systems struggle with waiting times for elective surgeries and specialty care. Those waits aren't mere annoyances. They can worsen quality of life and, in some cases, outcomes. If we move to a universal system without aggressive capacity planning and smart performance metrics, we risk trading one set of problems for another. Alex, queue management is a design problem, not destiny. The places that do this well invest in primary care, workforce, day surgery capacity, and digital scheduling. They publish wait time targets and fund to meet them. Meanwhile, our current model rations by price and paperwork. People skip treatment because of cost, take on medical debt, or delay needed care. Universal coverage flips that. Access is based on need. The financial protection gains alone are massive. Fewer bills in collections, fewer bankruptcies linked to medical debt, less fear attached to seeing a clinician. Blair, financial protection is important, but coverage is not the same as care. A lottery-based randomized study of coverage expansion showed improved mental health and financial security in the short run, yet limited changes in measured physical health at 2 years. That's a reminder that insurance isn't a magic wand. Delivery reform, not just financing, drives outcomes. If a universal system becomes a single bottleneck for payment and authorization, innovation and responsiveness can suffer. Alex, which is precisely why universal coverage should be paired with delivery reforms, global budgets with quality incentives, team-based primary care, risk-adjusted funding, and digital tools that expand access without overloading clinics. And about innovation, prices can be disciplined without starving research. Governments already co-fund basic science and early-stage development. You can layer targeted pull incentives, advance market commitments, milestone prizes on top of sensible pricing. The goal is to pay for value, not unchecked list prices. Blair, price discipline has consequences. A robust literature shows drug innovation responds to expected revenue. If we squeeze prices across the board, the pipeline could shrink, especially for high-risk projects with long timelines. Patients care about today's access, but they also care about tomorrow's cures. A policy that gets today's spending under control at the cost of fewer breakthroughs may not be a bargain. Alex, that's a false binary. We already pay far more than peers without proportionate gains. Aligning prices with value and cutting administrative waste does not mean annihilating revenue. And targeted innovation policy can be more efficient than paying inflated prices on every drug forever. Think of universal coverage as the floor. Above it, we design smart incentives for discovery where social value is highest. Blair, let's talk governance. Universal systems often centralize decision-making. Centralization can negotiate better and plan capacity, but it can also ossify. Targets get gamed, paperwork morphs into compliance rituals, and patients become numbers. If people feel the system is unresponsive, can't choose specialists, can't get timely surgery, they will seek private workarounds. That can create a two-tier reality despite the universal ideal. Alex, centralization is a choice, not a requirement. Universal coverage can coexist with pluralistic delivery, public hospitals, nonprofit networks, and regulated private providers. The key is universal, portable insurance with automatic enrollment and capped out-of-pocket costs. Within that, you can allow patient choice, benchmark competition, and transparent quality reporting. Far from ossifying, that setup can spur improvement because funds follow patients based on risk-adjusted formulas and quality performance. Blair, workforce is the binding constraint. You can promise coverage to everyone, but if you don't train and retain enough clinicians, access will disappoint. Many systems are already struggling to recruit nurses and GPS. Add universal entitlements without commensurate training slots, scope of practice reform, and immigration pathways, and you'll intensify shortages. Alex, agreed. Universal coverage must be sequenced with workforce policy. Expand training pipelines, support mid-level clinicians where safe, and streamline international credentialing while maintaining standards. Also, invest in prevention and chronic disease management so we reduce demand for acute care. Universal coverage makes prevention financeable. People don't avoid primary care because of cost, which helps manage downstream pressures. Blair, another concern is fiscal sustainability. A universal promise is politically sticky. If costs outrun productivity, governments face pressure to raise taxes, cut benefits, or both. Discipline is crucial. Rigorous health technology assessment, negotiated prices, and periodic benefit reviews. Without credible cost control, universal coverage can crowd out other public priorities. Alex, fiscal credibility is a feature, not a bug, of well-run universal systems. Using health technology assessment, reference pricing, and global budgets, they have kept overall spend as a share of GDP below ours while achieving broader coverage. Combine that with digital transformation, interoperable records, e-prescribing, telehealth triage, and you can bend cost growth while improving user experience. Blair, we're converging on important qualifiers. If universal coverage is pursued, it must 1. Fund and manage capacity to avoid harmful waits. 2. Implement value-based pricing without undermining R&D. 3. Protect patient choice and responsiveness. And 4. Hardwire transparency so the public sees wait time, quality, and outcome dashboards. Alex, and don't forget equity. Universal coverage closes gaps that fall hardest on low-income, rural, and minority communities. Financial protection is equity policy. But equity also means making access real. Mobile clinics, language support, travel vouchers, extended hours. The financing model enables it. Service design delivers it. Blair, if those guardrails are real, capacity, innovation policy, choice, transparency, I'm open to a universal scheme. But I'd phase it. Start with automatic enrollment and out-of-pocket caps, expand primary care, build workforce and data systems, and then tighten price negotiations as capacity comes online. Alex, a staged approach is sensible. Meanwhile, early wins, capping out-of-pocket costs, eliminating surprise billing, universal childhood vaccinations, mental health parity, build trust. As access stabilizes and administration shrinks, we reinvest savings in workforce and infrastructure. Blair, then perhaps we agree on the destination. Everyone covered, access delivered, prices aligned with value, and innovation safeguarded. The route matters as much as the goal. Alex, exactly. Universal healthcare isn't a single switch, it's a blueprint. If we build it with evidence and feedback loops, we can get the efficiency and equity gains without the pitfalls you warn about. Blair, Hold policymakers to those feedback loops. Publish performance, fix what underperforms, and don't hesitate to course correct. That's how a universal system earns its name and its legitimacy.